to answer in the end of this session. And I have a few announcements for you about our next activities from Congenital Heart Academy. Thank you so much for attending today. And if you find this session interesting, please share the YouTube link with your team. So just remind you that we have this amazing symposium now on our YouTube channel. And I want to remind you that the next session of Dr. Anderson's series is going to be on November 17. So only in 2 weeks time from now, we are going to talk and to have the next session. So please join us in 2 Thursdays from now. On November the 22nd, we are going to have Dr. Silverman, a session about the echo-morphological correlations of AVSD. And on December 16, we have our dear Dr. Mary Cohen talking about imaging in the ICU. It's going to be very interesting. And please take a minute to scan this QR code, and it's going to lead you to the World Congress of Pediatric Cardiology, Cardiac Surgery website. There you can subscribe for the newsletter and get to know more about this amazing meeting. Please save the date. It's going to be end of August, beginning of September 2023 in the US. And now with you, Dr. Anderson. Thank you, everybody for joining us today. And thank you again, Dr. Anderson, Justin, and Adrian for being with us today.
Well, good afternoon to you all, ladies and gentlemen. In this afternoon's session, I'm going to be joined by Diane and Justin, and we're going to be discussing with you the phenotypic variations that can be found when ventricular septal defects are said to be isolated. And what we're going to try to do is to revisit the concepts that we've shared with you in our previous sessions, where we have been discussing deficient ventricular septation. So I hope you're now all aware that the emphasis of our discussions has been remodeling of the embryonic interventricular communication. When we first see the interventricular communication, we think of it as a primary defect. And as you will remember, it then provides the outlet between the developing left ventricle and the developing right ventricle. And the first step we see is expansion of the atrioventricular canal. So this gives the right ventricle its own inlet, and then the interventricular communication, which is now the outlet for the left ventricle, is the secondary interventricular communication. The next step of development is transfer of the subaortic outlet to the left ventricle. And if all goes according to plan, this makes it possible for the embryo to close what has become the tertiary interventricular communication. But, as we will see, that does not always happen. And if we get persistence of a communication between the ventricles at this stage, when the right ventricle has achieved its own inlet, the subaortic outlet has been committed to the left ventricle, we can consider those channels to be isolated ventricular septal defects. And those are the lesions we're going to be discussing today. And what we're going to try to emphasize to you is the marked phenotypic variability that can be found in this setting. Now, I've introduced you to the notion that the subaortic outlet is being transferred to the left ventricle, but the variation we see can equally well be seen when it is the pulmonary trunk that is being transferred to the left ventricle. And then, of course, we have transposition. But for the larger part, today, we're going to be considering isolated defects in the setting of concordant atrioventricular and ventricular arterial connections. So why can't we find this phenotypic variation? There are three main reasons. We're going to start off by discussing the failure to close the tertiary interventricular foramen. But we can also have channels between the ventricles because the muscular ventricular septum has not been formed by appropriate coalescence of the trabeculations which make up its larger part. And then there is a third possibility, and that is down to inappropriate formation of the subpulmonary infundibulum. And we're going to try to illustrate all these processes to you, and we're going to emphasize again that these can be accompanied by malalignment of the septal components. But let's start by looking at failure to close the tertiary interventricular communication. Now, this is important because it underscores what is probably the commonest type of isolated defects that comes forward for surgical or transcatheter correction. And this is what we call the perimembranous defect. Now, that term itself has been controversial in the past, but we now know that the defect truly is perimembranous. And it is because the myocardial borders that surround the tertiary interventricular communication are themselves deficient, leaving a hole that is simply too large to be closed by the tubercles of the atrioventricular cushions. And I hope you remember it is these tubercles of the atrioventricular cushions that produce the membranous septum should septation be complete. So let's look at this process. And let me show you again this 4-chamber cut of a developing mouse heart late on embryonic day 12.5. And I hope you'll appreciate that you see the aortic root overriding the crest of the muscular ventricular septum. And the aortic root is in the process of being transferred into the left ventricle. So now the secondary interventricular communication is becoming transformed into what will be the left ventricular outflow tract. But what I hope you can also see is the persisting channel between the base of the aortic root and the right ventricle. And this, of course, is now the tertiary interventricular communication. Now I can take this data set and I can cut it along the line shown in white. And then I can turn the data set itself so that you're looking at the basal part from the apex of the ventricles. And this is what it looks like. So now to the bottom, you see the cavity of the developing left ventricle. And between the ventricular chambers, you see the ventricular septum. So you're now looking up into the roof of the right ventricle. And there you see the subpulmonary outflow tract. And here is the myocardial mass that has been formed by muscularization of the fused proximal cushions. And we'll come back to this process of muscularization of the cushions later in the presentation. But what I'd like to emphasize for you now is the presence of that channel in the roof of the right ventricle between the right ventricular cavity and the subaortic outflow tract. And this is the tertiary interventricular communication. It will eventually be closed to form the membranous septum. And there you see the tubercles of the atrioventricular cushions that are going to close this space. So this is the situation in the mouse heart. But we can see that exactly the same thing is taking place in the human heart. So once more, I'm reverting to these spectacular interactive PDF files prepared by Wout Lammers, Jill Hickspoors from the University of Maastricht in the Netherlands. And here you see in the human embryo at the end of the embryonic period, the aortic root is still straddling the crest of the muscular ventricular septum. And there you see how the secondary interventricular communication is being transformed into the left ventricular outflow tract. But the aortic root remains aligned with the cavity of the right ventricle. But by this stage in normal development, the tertiary interventricular communication has been closed by formation of the membranous septum. Now, this is what it looks like in an interactive PDF file. I can show you exactly the same thing in a histologic section from the Human Developmental Biology resource. So there you see a short axis of the pulmonary root, And there is the channel through which the secondary interventricular communication has been transformed into the left ventricular outflow tract. And now, very nicely, you see that if development has proceeded normally, those tubercles of the atrioventricular cushions have closed the tertiary interventricular communication and are now forming the membranous septum. And I can show you a mouse heart in which we have perturbed the furin enzyme, and that has stopped the heart from developing normally. And it's comparable to the situation I showed you earlier, where the aortic root was overriding the crest of the ventricular septum. So now you see how the secondary interventricular communication is becoming the left ventricular outflow tract, but in this mouse, because of the perturbation of the furin enzyme, the tertiary interventricular communication could not be closed. And so this is now persisting as a perimembranous ventricular septal defect. But note, there is a muscle mass that is interposing between the leaflets of the aortic and the tricuspid valves. And this shows us that the phenotypic feature for the perimembranous defect is fibrous continuity between the leaflets of the atrioventricular valves. That is, between the tricuspid valve and the mitral valve. And that is the phenotypic feature of the perimembranous defect. We used to think it was fibrous continuity between the leaflets of the aortic and tricuspid valves, and that is often the case, but not always. So now what we're going to emphasize is that it is the continuity between the mitral and tricuspid valves that is the unifying phenotypic feature. And what you're going to see very shortly is that such defects with this phenotypic feature can open centrally when they are small, and that is exactly where we expect to find the membranous septum. But if they are larger, they can extend so as to open to the inlet of the right ventricle, to the outlet of the right ventricle, or, if extensive, they can be confluent, opening to both the inlet and the outlet. And now Diane is going to show you this variation that we can find with perimembranous ventricular septal defects, and then Justin is going to reinforce that, showing you how in the clinical setting you can identify these phenotypic features, both echocardiographically and using computed tomographic data sets.
This central perimembranous ventricular septal defect is very much like the last heart that I showed you, where it lies beneath the zone of apposition between the septal and the anterior superior leaflets. And also, the supraventricular crest is inserted normally between the limbs of the septomarginal trabeculation. The difference and the reason that I'm showing you this specimen is that there is no aorta to tricuspid fibrous continuity, because there is a muscle bar, or the portion of the ventriculoinfundibular fold that remains intact, occurs between the tricuspid and the aortic valve. So that this specimen is perimembranous because there is fibrous continuity between the tricuspid valve and the mitral valve along the posterior inferior border. You can also see, again in this heart, a nice remnant of the membranous septum, or that membranous flap. Here we're looking at another central perimembranous ventricular septal defect and its borders as seen from the morphologically right ventricle. Here we can see the supraventricular crest inserting normally between the limbs of the septomarginal trabeculation, with its cephalic arm rising up to become part of the subpulmonary muscular infundibulum. And here we have the medial papillary muscle arising from the caudal arm, which reaches the inner heart curvature. The defect lies beneath the zone of apposition between the septal and anterior superior leaflets of the tricuspid valve, and this defect extends into the inlet component of the right ventricle, so that it is beneath the septal leaflet of the tricuspid valve. And you'll be able to appreciate that the border along the posterior inferior aspect of the defect is much closer to the coronary sinus than was the previous smaller central perimembranous ventricular septal defects. So this defect extends into the inlet component of the right ventricle. Looking at the defect from the left side, here we see this extensive area of fibrous continuity between the tricuspid valve and the mitral valve, which is the hallmark of a perimembranous ventricular septal defect. In this heart also we have fibrous continuity between the aortic valve and the tricuspid valve. Here we're looking at the outflow of a morphologically right ventricle. This right ventricle is actually somewhat hypertrophied. You can see the tricuspid valve in the inlet, and here is a perimembranous ventricular septal defect extending into the outlet of the right ventricle. The defect extends between the limbs of the septomarginal trabeculation limb here and the caudal limb, not extending to reach the inner heart curvature, so that we have an area of fibrous continuity between the tricuspid and the mitral valve along the posterior inferior border. This defect results in combination of hypoplasia of the proximal outflow cushions adjacent to the area where the muscular ventricular septum failed to compact. When we look at the left side of the defect, you can see that there is muscle separating the tricuspid valve from the aortic valve, and we have the hallmark of a perimembranous ventricular septal defect with fibrous continuity between the tricuspid and the mitral valve along the posterior inferior border. The free wall of this right ventricle has been folded away so that we can see the atrioventricular junction. There's the flap valve at the floor of the oval fossa, the coronary sinus, and the hinge point of the tricuspid valve. This specimen has a mid-muscular ventricular septal defect and a large perimembranous ventricular septal defect. The perimembranous defect extends into the inlet component of this right ventricle, or beneath the septal leaflet of the tricuspid valve, as well as into the outlet component of the ventricle, so between the limbs of the septomarginal trabeculation. Here we see the medial papillary muscle arising from the caudal limb and the cephalic limb rising up to become part of this anteriorly deviated outlet septum and the subpulmonary muscular infundibulum. So I will note that there is no pulmonary stenosis associated with this anterior malalignment. Because this defect extends into the inlet and outlet components of this right ventricle, we would call this a confluent defect. Looking at the left side, there is our mid-muscular ventricular septal defect with entirely muscular borders, and here we can see the perimembranous ventricular septal defect. The septal leaflet of the tricuspid valve is easily seen along the posterior inferior aspect of the defect, along with this extensive area of fibrous continuity between the mitral and tricuspid valves. In this confluent defect, we also have fibrous continuity between the aortic valve and the tricuspid valve, with the hallmark of a perimembranous defect, the fibrous continuity between the tricuspid and mitral valves along the posterior inferior border.
I wanted to review how we evaluate perimembranous ventricular septal defects by echocardiography, and really tried to understand the components that form the so-called central fibrous body, part of which becomes deficient in perimembranous ventricular septal defects. So this is an echo view on the left and a corresponding mirror image of a surgeon's view on the right, a 3D CT reconstruction, looking at the area of the so-called central fibrous body here on the right above the level of the left ventricular outflow tract at the aortic root. So if we look at the echo view, we're into the left ventricular outflow tract. We see the aortic mitral fibrous curtain, which is spanned by the left fibrous trigoon with the yellow circle, the right fibrous trigoon with the red circle, into the area of the roof of the infraseptal recess, which is formed by the area of fibrous continuity between the AV valves, and then the membranous septum, which is divided into an atrioventricular portion with this orange line, in the interventricular portion in the yellow line, divided by the attachment of the septal leaflet of the tricuspid valve. And then that is the fiber support of the aortic root. The ventricular myocardial support includes the interventricular septum and the free wall of the left ventricle. And the so-called central fibrous body then is comprised of the right fibrous trigoon, the roof of the infraseptal recess here, and the membranous septum. And if we look at this comparable 3D CT reconstruction and we start to cut down from the non-coronary sinus, which lines up with the atrial septum, and we get into the left ventricular outflow tract, we then see where that yellow diamond is, the right fibrous trigoon, the roof of the infraseptal recess, and then the membranous septum, again, forming the so-called central fibrous body. And so if we look at this cine echo going from base down towards the apex, I'll let it run through once. And then if we focus on this area again, and we try to tease out the various components, we see the aortic valve, the normal trileaflet aortic valve, and we start to go inferior, and we get into that aortic mitral fibrous curtain, and you can watch that run right down into the aortic leaflet of the mitral valve. I'm going to come back up and see that's the area of fibrous continuity between the mitral valve and the aortic valve. And its rightward aspect, its right lateral thickening, is the right fibrous trigoon. This area right here in the left ventricular outflow tract is the roof of the infraseptal recess, and then the membranous septum. You can also see this structure here, which is the medial papillary muscle, which often supports the commissure between the septal and anterior superior leaflet of the tricuspid valve. The septal leaflet of the tricuspid valve is right there, which is dividing the membranous septum into its interventricular and atrioventricular components. And so that's focusing on the so-called central fibrous body, which again, part of which becomes deficient. Specifically, the interventricular portion of the membranous septum becomes deficient in the perimembranous ventricoseptal defect. The perimembranous ventricoseptal defect can just involve that central area, which is near the interventricular portion of the membranous septum and some of the surrounding muscular tissue, or it can extend into the outlet, which is between the limbs of the septomarginal trabeculation out towards the subpulmonary infundibulum. It can extend to the inlet, which is the area from the hinge line of the septal leaflet down to its chordal and papillary muscle attachments. And then the other component of the right ventricle is the apical trabecular portion, which extends from the outlet and inlet down towards the apex of the right ventricle. So these are the four areas geographically that a ventricoseptal defect can open into the right ventricle. Again, with the perimembranous defect, it can extend to the outlet or to the inlet, or both, including it can extend into this area of the apical trabecular part of the septum. And so if we think about how we cut this by two-dimensional echo, I have some lines here that are rough cuts. Our apical cut would cut from posterior to anterior in this right anterior oblique view of the right ventricle. So it's cutting all four chambers across both of the AV valves. Our parasternal short axis view will cut more or less parallel to the plane of the vertebral basal ring of the aortic root, which is seen here wedged down in between the tricuspid valve on this side and the mitral valve on the other side. And you can see how that gives us a nice cut, being parallel to the vertebral basal ring, but then also showing the area that would open to the outlet of the right ventricle. Our subcostal short axis view gives a very nice cut more obliquely across the aortic valve, but then very parallel to the atrioventricular valves, and specifically the tricuspid valve. We can cut right down along the hinge line of the tricuspid valve leaflets, give a nice short axis en face view of that. So that gives a very nice view of understanding inlet extension of these ventricular septal defects. And so I want to walk through our perimembranous VSDs and whether they're extending to, whether they remain centrally or extend to the inlet or the outlet, and how we view these by two-dimensional echo. So this is a parasternal short axis view at the base of the heart at the aortic valve. And if we play it, we see there's left to right shunting through this relatively smaller defect. And if we slow it down and look at the components we looked at previously, right there is the medial papillary muscle, which is attaching anterior to the margin of the defect. Here is the septal leaflet of the tricuspid valve. The defect is located, if we think of this as a clock, around 9 to 10 o'clock. It's not extending to the outlet, open to the outlet of the right ventricle, which would extend to about 11 to 12 or even 1 o'clock if we thought about a clock face. And if we play through this and look at that septal leaflet, right there, we see that septal leaflet coming right into that aortic mitral fibrous curtain, that area of the remaining central fibrous body, the area, the roof of the infraseptal recess, which is allowing that mitral to tricuspid fibrous continuity. So this defines the phenotype of the perimembranous defect. So from a border standpoint, it's perimembranous. Geographically, it opens centrally. It doesn't extend into the outlet. We can't really tell the inlet in this view. So we turn our attention to a subcostal short axis view. We see the tricuspid valve en face, the septal, the inferior, the anterosuperior leaflet. We see the defect at the commissure here between the anterosuperior and septal leaflet, and it is not extending inferiorly under the septal leaflet. So it's not extending to open into the inlet. So it remains central. It's a perimembranous central VSD. So perimembranous inlet VSDs, historically, providers often turn their attention to a 4-chamber cut, which is good, but we can easily get an oblique plane in these long axis type cuts where we're not viewing valves en face and we can't be more certain of our plane of cut. So here is a 4-chamber view. We see all 4 chambers. We see the AV valves, they have lost their normal offset, which is not only seen in AV septal defects, but can also be in perimembranous inlet VSDs. So they've lost their normal offset, both the tricuspid and the mitral valve. We see them in fibrous continuity. This suggests that there's inlet extension. But better, we turn our attention to a subcostal short axis view like we discussed. We get that tricuspid valve en face. We see the commissure between the anterosuperior and septal leaflet. The area where the membranous septum would be is deficient right under the aortic valve. So it is perimembranous, and then the defect is extending inferiorly under the septal leaflet, so it extends the open into the inlet of the right ventricle. So it's perimembranous inlet. Because it's perimembranous, that we know the conduction axis will run along the posterior inferior margin of the defect. And that's much different than the muscular inlet defect, where here in an apical view, we retain our normal offsetting right there, the mitral valve right there, the hinge line of the septal leaflet of the tricuspid valve. We see this muscle underneath both, suggesting that it's not a perimembranous defect. However, better to turn our attention to the subcostal short axis. We see the septal leaflet of the tricuspid valve, the membranous septum up here with muscle underneath, and the defect is much more inferior under the septal leaflet, so it's muscular inlet. And if we look at these videos, a sweep through the 4-chamber plane, we see that muscle right there. I'll slow it down. So right there, we see the muscle under the mitral and tricuspid valve with their offset retained, again, suggesting a muscular inlet defect. We look at the subcostal view and we get that tricuspid valve en face, anterosuperior, septal leaflet. There's the membranous septum with muscle inferior. The defect is much more inferior to that. So it's a muscular inlet defect. And now the conduction system runs anterior and relatively remote to the margins of the defect. So very important to distinguish from a perimembranous inlet defect. And then lastly, thinking about outlet extension, if we look at a parasternal long axis at the left ventricular outflow tract, the aortic valve, there's a defect there under the aortic valve. There's the outlet septum. It's tipped anteriorly. We look at the parasternal short axis view, the aortic valve en face. We see the defect extending from 9 to about 12 o'clock. There's the medial papillary muscle attaching to the anterior margin of the defect. That, however, can be highly variable, but just wanted to point it out. there's the septal leaflet, and we see it going right down into the aortic mitral fibrous curtain, into that remaining area of the central fibrous body. See if we right there. So we see the septal leaflet coming right down into the area of the right fibrous trigone in the aortic mitral fibrous curtain. So this is a perimembranous defect. It's opening to the outlet of the right ventricle, and the outlet septum seen here is anteriorly deviated into the right ventricular outflow tract. However, unlike tetralogy of flow, we see a very well-developed subpulmonary infundibulum with no subpulmonary obstruction. So this is a perimembranous outlet VSD with anterior malalignment of the outlet septum. And because of the borders of the defect, because it's perimembranous, we know the conduction axis runs along the posterior inferior margin. And to confirm, to look at the subcostal short axis view, we see at the commissure between the anterior superior leaflet and the septal leaflet, the defect under the aortic valve with no extension inferiorly, so it doesn't open into the inlet of the right ventricle. So a perimembranous outlet VSD with anterior malalignment of the outlet septum.
So now you've seen how we recognize the phenotype. But why is that important? It is important because when we have this fibrous continuity between the leaflets, the mitral and tricuspid valves, forming the posterior inferior border of the defects, then always in the presence of septal alignment, the atrioventricular conduction axis penetrates through that area of fibrous continuity. And that tells us that when we have this phenotype, always, when viewed from the right ventricle, the conduction axis will be running postero-inferiorly. And in the operating room, the surgeon can trace the likely course of the axis by following a line from the apex of the triangle of Koch to the medial papillary muscle. So now let's look at how we can find this in the heart, in the gross autopsied heart, and again using virtual dissection.
Here we see a perimembranous ventricular septal defect that is extending into the inlet component of this right ventricle so that it lies beneath the septal leaflet of the tricuspid valve. When you have a defect like this, the triangle of Koch can no longer have its apex at its normal position, so the triangle gets attenuated with its apex here where the crest of the muscular ventricular septum meets the atrial musculature. So along the posterior inferior border of the defect, you'll have your long non-branching bundle towards the left side of that septum, and we can anticipate where the right bundle branch will emerge by marking the medial papillary muscle, and then it will extend onto the septomarginal trabeculation. When we look at the left side of the defect, here is our extensive area of tricuspid to mitral valve fibrous continuity, and as we have mentioned, the conduction axis will emerge along the posterior inferior border of the defect where the tricuspid valve and mitral valve are in fibrous continuity with one another, so that the left bundle branch will then extend along the crest of the septum to ramify over the septal surface within the left ventricle. This is a perimembranous ventricular septal defect that extends into the outlet component of this right ventricle. And by that I mean it extends between the limbs of the septomarginal trabeculation. The septomarginal trabeculation is this prominent septal structure within the right ventricle, and the cephalic arm extends up to become part of the subpulmonary muscular infundibulum, with the caudal arm deficient in this case and not reaching the inner heart curvature. And this is the area where we end up with the tricuspid to mitral valve fibrous continuity along the posterior inferior border. If we want to give the surgeon an idea of where the conduction tissue will be located, we need to mark the triangle of Koch, and if I pull on the coronary sinus, you can see the tendon of Tadaro becoming a prominent structure, along with the hinge line of the tricuspid valve, marking the apex of that triangle, which will be along that posterior inferior border of the defect. And by tracing a line from the apex of the triangle of Koch towards the medial papillary muscle. We can see where the right bundle branch will emerge and extend onto the septomarginal trabeculation. Looking at the left side of the defect, we know that the left bundle branch will emerge in the area where there is mitral to tricuspid fibrous continuity, and it will extend along the crest of the ventricular septum to ramify over the left ventricular surface of the septum. You can see the defect is perimembranous by this area of mitral to tricuspid fibrous continuity. In this case, there is also aortic to tricuspid fibrous continuity.
This is a CT 3D reconstruction that we had gone over in the last session. This is a baby that had aortic coarctation, that had a CT scan to define that, but here we're looking at the ventriculoseptal defect. So we're dissecting into the left ventricle in a 3-chamber view, left atrium, left ventricle, left ventricular outflow tract, and the aortic valve. We see the defect under the aortic valve, and we see the outlet septum, which is deviated towards us or deviated posteriorly under the left ventricular outflow tract and the aortic valve, which led to some left ventricular outflow tract obstruction. The defect is relatively small, and right there is the aortic leaflet of the mitral valve. This is the roof of the infraseptal recess, that area of fibrous continuity between the mitral to tricuspid valve, which is bordering the posterior aspect of this small defect. So this is a perimembranous ventriculoseptal defect. And this highlighted, like we showed in this example from the paper that we reviewed, looking from the left ventricular aspect here, where there was no tricuspid to aortic fibrous continuity in this example. This is the same thing where this muscle bar, this outlet septum deviated posteriorly, has made it so that there is no fibrous continuity between the tricuspid to aortic valve. So this we found in about 20% of patients where they did not have aortic to tricuspid valve fibrous continuity. However, 100% have tricuspid to mitral valve fibrous continuity. And then we go into the short axis and a surgeon's view. There's the septal leaflet of the tricuspid valve. There is this relatively small perimembranous VSD, which abuts right up to the septal leaflet of the tricuspid valve. The defect stays right. If we think of the reverse clock face of what we would see in echo, this would be 9 to 11 o'clock. So it stays in this to open more centrally into the right ventricle. And then if we go into a right anterior oblique view to view the right side of the interventricular septum, there's the right ventricular outflow tract to the pulmonary valve, the aortic root wedge between the septal leaflet of the tricuspid valve, the right ventricle's inlet, apical trabecular. There's the septomarginal trabeculation. So this is the outlet leading up to the pulmonary valve. The defect is located just centrally. So this is a central perimembranous VSD that's centrally located, or perimembranous central VSD, or I would just not specify and say a small perimembranous VSD. So if we think about where the conduction system is, then because we've defined the borders to be perimembranous, the conduction axis will run along the posterior inferior margin of the defect. And if we go back to how we can understand the conduction system, looking at a similar right anterior oblique view and understanding the triangle of Koch seen here, that it really is this 3-dimensional pyramid underneath. And if we make the myocardium translucent, and then we can see the upward directed apex of the inferior pyramidal space, which overlaps the downward directed apex of the floor of the infraseptal recess. The AV node will be located at the apex of the inferior pyramidal space. The penetrating bundle then penetrates through the roof of the infraseptal recess to gain access into the ventricular mass. And then it'll course under the inferior margin of the membranous septum before giving rise to the bundle branches. So if we look at that same anatomy, here are the heart specimens showing this beautiful dissection Diane did to show the inferior pyramidal space underneath the myocardium of the the right atrium in this area here, leading up to the tricuspid valve. So if we take this information and we apply it to our patient, then we can find, here's the triangle of Koch, and looking at the inferior pyramidal space, it was located here. The atrioventricular portion of the membranous septum is intact, so we know the conduction axis will run and penetrate and course under that, course under the inferior margin of the defect, and then it'll start to give rise to the bundle branches, with the right bundle branch and coursing down the septum marginal trabeculation here. So we can estimate where we think this conduction axis is going to run based on an understanding of this anatomy.
So that is the situation when we have perimembranous defects with septal alignment. But as we've emphasized in our previous sessions, we can also have perimembranous defects when the septal structures are malaligned, one relative to the other. But that malalignment does not disturb the basic phenotype. And so, when the outlet septum is malaligned, it can produce obstruction of either the right or the left ventricular outflow tract, but since it has not changed the phenotype, it has not changed the course of the conduction axis. So let's now look at this situation, again with autopsy specimens and with virtual dissection.
This right ventricle has been windowed so that the tricuspid valve, or the inlet component, has been left intact. You'll appreciate that there's a large ventricular septal defect that extends to become perimembranous and extends into the outlet component of the right ventricle, so between the limbs of the septomarginal trabeculation. If I tilt the specimen a bit, you can see that there is fibrous continuity between the tricuspid and mitral valves along the posterior inferior border, and here's the medial papillary muscle arising from the caudal limb of the septomarginal trabeculation. There's a bit of hypoplasia associated with the subpulmonary muscular infundibulum, and as well there is caudal or posterior malalignment of the outlet septum. The conduction tissue, despite the caudal malalignment of the outlet septum, will continue to run along the posterior inferior border of the defect, and because the defect is perimembranous, the surgeon will need to be careful where they place their sutures relative to the borders, or the posterior inferior border of this defect. So the right bundle branch will emerge relative to the medial papillary muscle and extend along the septomarginal trabeculation. Looking up the barrel of this left ventricle, here's the mitral valve inlet, and this is the aortic valve. The posterior or caudal malalignment of the outlet septum has created this muscle bar, which is causing subaortic stenosis. Looking at the outflow tract, there is the muscle bar between the tricuspid and the aortic valves, so no tricuspid to aortic valve fibrous continuity. But if we look a little closer, here we see our fibrous continuity along the posterior inferior border between the tricuspid valve and the mitral valve, so that the conduction tissue will continue to arise along the posterior inferior border of the defect, the left bundle branch emerging at this area of tricuspid to mitral fibrous continuity, and then ramifying over the crest of the ventricular septum.
These are echo images of a patient with a perimembranous outlet ventricular septal defect with posterior deviation of the outlet septum. So if we look at the peristernal long axis view, in the left ventricular outflow tract, the aortic valve, the plane of the virtual basal ring is relatively hypoplastic. There's the outlet septum, which is now tipped posteriorly into the left ventricular outflow tract under the aortic valve, causing subaortic obstruction. And if we look at the peristernal short axis view, which is going from the aortic root down into the left ventricular outflow tract, we again see the outlet septum deviated posteriorly down into the left ventricular outflow tract. And if we look at the borders of the defect, there's the aortomitral fibrous curtain, the right fibrous trigoon, the floor the roof of the infraseptal recess, the septal leaflet of the tricuspid valve, is in fibrous continuity with these structures. So there's fibrous continuity between the AV valves. This is perimembranous. The defect extends from around 9 to 10 o'clock towards around 12 o'clock. So it extends into the outlet to open into the outlet of the right ventricle. So this is a perimembranous outlet ventricoseptal defect with posterior malalignment of the outlet septum.
So we've looked at the consequence of malalignment of the outlet septum, but you're all well aware now that it is not only the outlet septum that can be malaligned. We can also have the situation where there is malalignment between the atrial septum and the ventricular septum. And that is the consequence of incomplete expansion during the first stage of remodeling of the atrioventricular canal. So when we have such incomplete expansion, we have straddling and overriding of the tricuspid valve. And because of that straddling and overriding, the muscular ventricular septum no longer reaches to the crux of the heart. Because of that, the atrioventricular node will be formed at the site where the septum, and hence the conduction axis, meets the right atrioventricular junction. Now, it's important to remember that if we look into the left ventricle, there will still be fibrous continuity between the leaflets of the mitral and tricuspid valves. So this will be a perimembranous defect. And you're going to see that very shortly when Diane shows you an arrangement of a perimembranous defect with atrioventricular septal malalignment. She's going to show you first from the right side, and then she'll finish by showing you the arrangement from the left. And note at that point the fibrous continuity between the leaflets of the mitral and tricuspid valves. And then we hope Justin will be able to reinforce this with a computed tomographic data set.
This is a very nice specimen from the Idris archive at the Lurie Children's Hospital in Chicago, and it is showing a straddling and overriding of the tricuspid valve. The muscular interventricular septum in these cases no longer reaches or extends to the crux of the heart, and this is secondary to malalignment between the atrial and ventricular septums. And this is a consequence of incomplete expansion of the atrioventricular canal during development. The atrioventricular conduction axis can no longer be located in its normal position at the apex of the triangle of Koch, and that's secondary to this atrial and ventricular septal malalignment. So it gets repositioned in an abnormal location where the crest of the muscular ventricular septum meets the atrial musculature, and in these cases there's a long non-branching bundle with variable branching of the left bundle branch across the crest of the muscular ventricular septum, but we can predict where the right bundle branch will emerge by marking the medial papillary muscle, and it will emerge in this position and extend onto the septomarginal trabeculation. If we look at this on the short axis, you can see how the atrial and ventricular septums are malaligned, and when we look at the left ventricular aspect, there is a small papillary muscle across the interventricular septum and supporting the tricuspid valve within the left ventricle.
This is a patient with a perimembranous inlet ventricoseptal defect with atrial and ventricoseptal malalignment. Here is a four-chamber view in this left-hand image, and we can see very clearly this large ventricoseptal defect under the mitral and tricuspid valve. We've lost the normal offset of the AV valves. The defect extends right up underneath with fibrous continuity between the AV valves. So this is perimembranous. It's very clear from this view that it opens into the inlet of the right ventricle. There's override of the tricuspid valve over the crest of the ventricoseptum. And although not shown well in these images, there's also straddling with chordal attachments of the tricuspid valve over into the left ventricle. And importantly, if we look at the plane of the atrial and ventricoseptum, they're very clearly malaligned. And this is a similar view now sweeping into the left ventricular outflow tract, and we see the defect extend right up up under the aortic valve. And if we pay attention and we look here in this 4-chamber view, there's the septal leaflet of the tricuspid valve. We then get 2 leaflets, the septal and the anterior superior leaflet. Here's the commissure of both. And then we continue to come up and we get back to just 1 leaflet, which represents the anterior superior leaflet, which is in fibrous continuity with the aortic valve. So there's both fibrous continuity between the AV valves along with the tricuspid to aortic valve. So this again is a perimembranous inlet VSD with atrioventricular septal malalignment. And this is a figure from our textbook chapter in Anderson's Pediatric Cardiology showing how normally in the normal heart there's alignment between the atrioventricular septums, as opposed to this same patient which shows malalignment in this perimembranous inlet VSD. This is about 10 to 15% of perimembranous inlet VSDs. And importantly, what this indicates, as was discussed, is that the conduction axis, instead of the AV node being found at the apex of the triangle of Koch, is displaced posteriorly and inferiorly where the crest of the septum meets the right AV junction. And we'll look at that in more detail. And this is the subcostal short axis image, which shows the septal leaflet en face and the anterior superior and inferior leaflet, and the defect extending from the commissure between the anterior superior and septal leaflet inferiorly under the septal leaflet. So extending into the inlet of what opens into the inlet of the right ventricle. So this is a patient that we had gone over in the last session, which has a perimembranous inlet VSD with malalignment of the atrioventricular septum. So as we cut into a 4-chamber view, we see the same anatomy we saw previously, override of the tricuspid valve and straddling the defect going right up to the AV valves. This patient had a Fontan palliation, there's the Fontan, and had oversewing of the mitral valve here. And so this is a perimembranous inlet VSD. The floor of the oval fossa has been resected to allow interatrial shunting. But if we imagine the plane here, we can clearly see malalignment between the atrium and the ventricular septum, like our other patient. And then if we rotate into a right anterior oblique view, then we can see the crest of the septum coming deviated towards us rightward, along the right AV junction. So the AV node is going to be anomalously positioned posterior and inferiorly in this position. And we'll go into more detail in the next slide. But this is in comparison here to this very similar heart specimen viewed in a right anterior oblique view, where Diane has marked the crest of the ventricular septum, and the AV node is going to be displaced posteriorly and inferiorly from its normal position at the apex of the triangle of Koch. And so here is just paying attention then to the conduction system. I've made it so we can better see the opening of the coronary sinus in the right atrium. The atrial septum's been resected. There's the tendon of Todaro, the septal leaflet hinge line, so the apex of the triangle of Koch here. So the AV node would be normally positioned here, but instead, if we look at the crest of the septum where it meets the right AV junction here, and I'll rotate it so we can better appreciate. So you see the crest of the septum coming right there. So that node is going to be posterior and inferiorly displaced near where the crest of the septum is meeting the right AV junction.
So now you've seen the variation, the marked phenotypic variation we can find with perimembranous ventricular septal defects. But I started off by emphasizing that that is not the only reason why you can have so-called isolated defects. So now let's look at the second mechanism that can give us such isolated defects, and this is incomplete compaction of the ventricular septum. It's very possible that these are the commonest defects, although we may not always see them because many of them close spontaneously. Now, when we talk about compaction, it's often thought that the ventricular walls themselves grow by a process of compaction of pre-existing trabeculations. We now know this is not true. What is called non-compaction should be better described as being excessive trabeculation. But when we think of non-compaction, that is true for the muscular ventricular septum, because that does form by the process of coalescence of pre-existing aggregates of ventricular myocardium. But that itself does not always go smoothly, and on occasion, incomplete compaction can result in defects anywhere within the septum, producing the sponge-like arrangement, which we call the Swiss cheese septum. So here you see the situation, giving us a Swiss cheese septum, and this is another of our hearts in which we perturbed the furin enzyme. And you can see those multiple channels that course through the compacting ventricular septum in the fashion of a Swiss cheese.
I'm starting with a specimen that has actually an unbalanced atrioventricular septal defect, so you can see the slit-like left ventricle here and the dominant right ventricle here. And the reason I'm showing you this specimen is because it reminded me very much of the mouse four-chamber view that Professor Anderson showed you, and when I put some tension on the septum, you can see multiple defects across the muscular interventricular septum, and this reflects the inappropriate compaction of the muscle during development. So I thought this was just a nice four-chamber cut to show you a similar view to what the mouse heart showed in the PowerPoint. If we look at a heart that does have multiple apical ventricular septal defects, this specimen again has been windowed, or the free wall of the right ventricle has been removed, so the tricuspid valve is intact in the inlet and the pulmonary valve intact within the outlet of this right ventricle. And looking at the apex, there are multiple tiny ventricular septal defects. Actually, this one not so tiny, but multiple defects secondary to inappropriate compaction of the muscular interventricular septum. And if I go down a little closer and tilt the specimen, you can see all of those defects within the apical component. Looking at the left side, which has also been windowed, those defects are not as easy to see, but they are crossed by all of these increased trabeculations, and there are multiple holes within the apical, actually the mid to apical component of this muscular interventricular septum.
But more often, the aggregates come together and they leave more discrete holes within the ventricular septum. And those holes can be produced anywhere within the muscular septum. So they can be present opening either to the inlet or within the apical parts of the right ventricle. Now, the significant point here, if we have such a punched out hole that is opening to the inlet of the right ventricle, it will not have disturbed the formation of the conduction axis. So in this situation, the conduction axis will be superior to the interventricular communication, the communication itself being inferiorly located. And now we'll see that in an autopsied specimen.
Looking at this open right atrioventricular junction, you can see that there are multiple defects or fenestrations in the flap valve at the floor of the oval fossa, and there's also a ventricular septal defect that lies beneath the septal leaflet of the tricuspid valve. If I lift that leaflet up, the borders of this defect are entirely muscular, so this is a muscular inlet ventricular septal defect. Marking the apex of the triangle of Koch by tugging on the eustachian valve, we can see the tendon of Tadaro and the hinge point of the tricuspid valve forming the apex of that triangle. And you can see that the conduction tissues will run well away and in anterior superior position relative to the muscular borders of this VSD. So here, if we trace a line from the apex of the triangle of Koch to the medial papillary muscle, you can see where the right bundle branch will emerge and run along the septomarginal trabeculation. If we look at the left side of the defect, you can see nicely its muscular borders. and that the membranous septum remains intact at the base of the inner leaflet triangle between the right coronary and non-coronary aortic valvular sinuses, so that the conduction tissue or the left bundle branch will emerge in this area at the apex of the inferoseptal recess, where the tricuspid and mitral valves are in fibrous continuity. It will then ramify over the left ventricular septal surface. This is a very nice specimen that I've accessed from the Idris Archive at the Lurie Children's Hospital in Chicago, and it will show us where the conduction tissue runs when we have coexistence of a muscular and a perimembranous ventricular septal defect in the same specimen. So here, in the inlet component and beneath the septal leaflet of the tricuspid valve, is a muscular inlet ventricular septal defect. And in this area is a small central perimembranous ventricular septal defect, and it is a central defect because the supraventricular crest inserts normally between the limbs of the septomarginal trabeculation, with the cephalic arm here and the caudal arm extending to reach the inner heart curvature, and with the medial papillary muscle arising from that caudal limb. The conduction tissue will run in anterior superior location relative to the muscular ventricular septal defect, and in posterior inferior position relative to the perimembranous defect. So if we mark the apex of the triangle of Koch and trace a line to the medial papillary muscle, we can see where that right bundle branch will emerge and run along the septomarginal trabeculation. So it will run posterior inferior to the perimembranous defect and in anterior superior position relative to the muscular borders of that inlet defect. When we look at the left side of the specimen, we can see nicely both of the defects, the muscular inlet defect with its muscular borders and this muscular bar in between it and the perimembranous defect. This is the area of mitral to tricuspid valve fibrous continuity, and there's a tiny little remnant of a membranous flap here, representing where the membranous septum should have formed, so that the left bundle branch will emerge in the area where the mitral to tricuspid fibrous continuity occurs and run along the posterior inferior border of the perimembranous ventricular septal defect and along the anterior superior border of the muscular ventricular septal defect.
But if the septum fails to compact, we can have such defects opening to the inlet or to the apical part. We can also, however, have defects, muscular defects, that open to the right ventricular outlet. And they can have exclusively muscular borders. But this is not due to incomplete compaction of the septum. And that is because the outlet of the right ventricle is formed by yet another mechanism, by muscularization of the proximal outflow cushions. And then when we have a muscular outlet defect, it is because those muscularized cushions have not fused properly with the apical part of the ventricular septum. But what we're going to see, we can also have hypoplasia of those cushions, in which compaction of trabeculations produces discontinuity between the leaflets of the aortic and tricuspid valves, and it is that compaction of trabeculations that has produced the posterior-inferior muscular border. And when formed, that muscular posterior-inferior border has an important additional feature because it protects the atrioventricular conduction axis. So how does all this come about? Well, let me take you back to the situation prior to the transfer of the subaortic outflow tract to the left ventricle. And we see this at the end of the 7th week of normal human development. Again, I'm showing you one of the interactive PDF files created by Wout and Jill at the University of Maastricht. And here you're looking at the right side of the developing right ventricle. So in yellow, you see the atrioventricular canal myocardium. There you see the developing leaflets of the tricuspid valve, and in green, we're looking at the right side of the muscular ventricular septum, and we've seen that this forms by compaction of aggregates of ventricular cardiomyocytes. But now we've also put in the intrapericardial arterial trunks, and there you see the separated arterial roots. And at this stage, the left ventricle opens into the developing right ventricle through the secondary interventricular foramen. So what is it that transfers the aortic root into the left ventricle? And as we have discussed previously, it is muscularization of those proximal outflow cushions that builds a shelf so as to tunnel the aortic root through the secondary interventricular communication into the left ventricle. And if all goes according to plan, that builds the shelf, permitting the tubercles of the atrioventricular cushions to close the tertiary interventricular communication. But what happens if the cushions do not muscularize properly? Well, we can see the results of that process in another of our mice in which we perturbed the furin enzyme. So here again, you're looking at the right side of the septum. I hope you can recognize there the aortic valve guarding the aortic root. There, the underside of the pulmonary valve guarding the pulmonary root. But in this mouse heart, because of perturbation of the furin enzyme, the outflow cushions are remarkably hypoplastic and they have not muscularized. And that leaves us this outlet defect, which is doubly committed and juxta-arterial. So now let's look at that with muscular posterior inferior rim protecting the conduction axis.
This is a muscular ventricular septal defect that extends into the outlet component of the right ventricle. And by that, I mean it extends between the limbs of the septomarginal trabeculation. The septomarginal trabeculation is this prominent right ventricular septal structure, or trabeculation, with its cephalic arm rising up to become part of the subpulmonary muscular infundibulum. And in this case, the caudal arm reaches the inner heart curvature, protecting the conduction axis with this posterior inferior muscular bar. If we mark the apex of the triangle of Kalk, it will be just at the tip of my probe, and the membranous septum will remain intact in this case because of this posterior inferior muscular bar, so that the conduction axis will run between the membranous septum and the crest of the muscular ventricular septum, with the right bundle branch emerging relative to the position of the medial papillary muscle and then extending along the septomarginal trabeculation. Looking at the left side of the defect, the muscular bar is easily seen between the aortic and tricuspid valve, and there is the muscular bar along the posterior inferior border, separating the mitral and tricuspid valves. So this is a muscular outlet defect with no fibrous continuity between the atrioventricular valves. The membranous septum will remain intact in this area where my probe is pressing, so that the conduction axis will emerge in this area and extend along the crest of the ventricular septum to ramify over the left ventricular septal surface.
This is a patient that has a muscular outlet ventricoseptal defect. So we're in a parasternal short axis at the aortic valve, dipping down into the left ventricular outflow tract. We see the septal leaflet of the tricuspid valve. We're getting down towards the membranous septum, in and out of the membranous septum here. And then we see this muscle bar of tissue anteriorly. Right there, we see on color flow very clearly the left to right shunting through this relatively small VSD, which again, if we think of the clock face, is at 12 o'clock. So it's right in the outlet. It's not extending towards that 9 to 10 o'clock position where a perimembranous defect would extend to. And if I slow it down, we see this muscle right there, and that represents the posterior caudal limb of the septal marginal trabeculation coming right up at us. So that is intact. That forms the posterior margin of the defect. And there's some lung artifact in the right ventricular outflow tract, but we can see right there the pulmonary valve. So there has been some formation of the subpulmonary infundibulum to lift the pulmonary valve off the base of the heart. So it's at around, again, if we think of the clock face, around 3 o'clock here, with muscle between the defect and the pulmonary valve. So this is a muscular outlet defect. There is not fibrous continuity between the semilunar valves because of this muscular tissue here of the infundibulum, and there's not fibrous continuity between the AV valves because the posterior caudal limb is intact.
So it is failure to muscularize those proximal outflow cushions that produces the defects that are juxta-arterial and doubly committed. And should the outflow cushions be partially muscularized, it can give us a muscular outlet defect. As you have seen, usually the defects have a muscular posterior inferior border. And when present, it is that border which protects the conduction axis. But sometimes that muscular border does not form, and then the defects can extend to become perimembranous, leaving an area of tricuspid to mitral fibrous continuity posterior inferiorly, and meaning that the conduction axis will then be at risk. And equally, they can have malalignment of that fibrous outlet septum. So now we're going to look at these features again.
Looking at the outlet component of this markedly hypertrophied right ventricle, we see a ventricular septal defect that is a muscular outlet defect and is also doubly committed and juxta-arterial. The defect extends between the limbs of the septomarginal trabeculation, qualifying it as an outlet defect with the cephalic limb here and the caudal limb reaching the inner heart curvature and forming that protective posterior inferior muscular bar relative to the conduction tissues. The defect is doubly committed and juxta-arterial because we see one of the hallmarks of the defect with fibrous continuity between the pulmonary valve and the aortic valve at its roof. This defect forms secondary to hypoplasia of the proximal outflow cushions, allowing for poor formation of the subpulmonary muscular infundibulum and the pulmonary valve not being lifted up off of the right ventricular mass as we see in the normal heart. So this allows for the pulmonary valve and the aortic valve to remain at the same level, producing this fibrous continuity at the roof of the defect. The membranous septum will remain intact in this specimen where my probe is pointing, and we can anticipate the apex of the triangle of Koch is in this area. If we trace a line from the apex of the triangle of Koch to the medial papillary muscle, we see where the right bundle branch will emerge and extend along the septomarginal trabeculation, so that this posterior inferior muscular bar is protective of the conduction tissues. When we look at the left side of the defect, here we see that posterior inferior muscular bar, and the membranous septum will remain intact in this specimen at the base of the interleaflet triangle between the right and non-coronary aortic valvar sinuses. The hallmark of the defect can be seen by lifting up the aortic valve to show us that fibrous continuity between the aortic valve and pulmonary valve in the roof of the defect. So the conduction tissues will emerge at the apex of the inferoseptal recess and extend between the membranous and the muscular ventricular septum, with the left bundle branch emerging here. And as Professor Anderson says, with the eye of faith, you can even see some of the fascicles extending over the left ventricular septal surface. This doubly committed and juxta-arterial ventricular septal defect shows us similar features to the last heart we looked at, so that there is fibrous continuity between the pulmonary and aortic valves at the roof of the defect, and it's quite extensive in this case. And the defect extends into the outlet component of the right ventricle, so between the limbs of the septomarginal trabeculation. The difference is that this defect extends to become perimembranous. So along the posterior inferior border, there's fibrous continuity between the tricuspid and mitral valves, and the conduction tissue will now be in jeopardy as it runs along this posterior inferior border or perimembranous border of the ventricular septal defect. Looking at the left side and up the barrel of the left ventricle, this heart shows us that the fibrous continuity between the aortic valve and the pulmonary valve can also take some posterior or caudal deviation, so that there is some degree of subaortic stenosis in this case. Looking at the aorta to pulmonary fibrous continuity, you can see again it's quite extensive. And when we look at the posterior inferior border of the defect, this is where we see our tricuspid to mitral valve fibrous continuity, rendering this as a perimembranous ventricular septal defect. The conduction tissue or the left bundle branch will emerge along this posterior inferior border of the defect and then ramify over the septal surface of the left ventricle.
This is a patient with a doubly committed and juxta-arterial ventriculoseptal defect. So again, which by default opens into the outlet of the right ventricle. To define defects that open into the outlet, best defined by parasternal short axis imaging. And so this, if we again think of the clock face, here is the aortic root. The defect is at 12 o'clock, just like that muscular outlet defect. We see that muscle there between the membranous septum and the defect. So this is the posterior caudal limb coming up at us. We see the septal leaflet hinge line attaching down here. So the defect is not perimembranous. However, now the infundibulum has not formed because that proximal outflow cushion has not properly formed. So the pulmonary root now is not lifted up and away from the base of the heart. So instead of seeing it down here at around 3 o'clock, we now see it closer to about 12 to 1 o'clock. And it's right up to the margin of the defect. If I slow this down and we look at that pulmonary valve, we can see right there the aortic valve is in fibrous continuity there into the pulmonary valve. So there's fibrous continuity between the semilunar valves at the anterior and superior margin of the defect. So this is a doubly committed defect that does not extend to be perimembranous. So the posterior caudal limb is protecting the conduction axis, which is posterior and inferior to that. And this is in contrast. If we look at this right-hand image, we have a very similar appearance with the anterior and superior margin of the defect extending right up to the pulmonary valve, which sits much more proximally than usual. Again, the subpulmonary infundibulum has not formed normally. And so there is that aortic to pulmonary valve fibrous continuity. But if we look at the posterior margin of the defect, there is the septal leaflet of the tricuspid valve, and it's attaching right there, and it's going right into the area of the aortic mitral fibrous curtain there, along with the aortic valve. So it's in fibrous continuity with both the aortic valve and with the mitral valve. So this is a doubly committed and juxta-arterial defect because of the semilunar fibrous continuity, but it also extends to become perimembranous. So now the conduction axis does run right along the posterior inferior margin and is much more vulnerable to damage in this right-hand image compared to the left-hand image.
So there we are. We've looked at a lot of defects, and you've seen how they can be identified in the autopsy room. And Justin has now shown you how you can identify these phenotypic features in the clinical setting. And what we've tried to emphasize is that the phenotypic features depend on recognizing the borders, but we've also shown that the phenotypic features themselves can vary depending on how those defects open into the right ventricle. So the borders are important, so is the geography. However, It is the variation in their borders, hopefully by now that we've shown you, determines the basic phenotype. And once you know the phenotype, you can then make inferences precisely to demonstrate the course of the atrioventricular conduction axis. But remember, there can be malalignment. You've seen malalignment between the muscular ventricular septum, the outlet septum. That is the commonest type of malalignment. But you've also seen the significance of malalignment between the atrial septum and the muscular septum. And that means the conduction axis arises from an anomalous atrioventricular node. So the bottom line, borders are the number one feature, geography is another important feature, and so is malalignment. But the malalignment is not a phenotypic feature in its own right. The geography is not a phenotypic feature in its own right. It is the variation in the borders that is the major feature, giving us phenotypic variability in isolated ventricular septal defects. Well, hi. I hope those of you who have been with us enjoyed all those presentations. I have to say it's the first time I've seen all of that together. I thought it all came together wonderfully well, but I recognize my own bias. We have Justin and Diane with us, but we also have Adrian with us. Adrian, maybe you would like to give us your impression of what you've just seen.
So thank you very much. It's been a wonderful presentation. I think it's important that it's uploaded on the channel so we can watch it again. I wanted to ask first, how confident are we that on echo we can diagnose the different type of tissue between fibrous and muscular? That would be a first question.
Let's stop there, Adrian, let's stop there and let Justin answer that.
Yeah.
Yeah, and we've had a lot of those discussions in these kind of talks. Recently, when Professor Anderson visited us here at the Cleveland Clinic, that was something that had come up in one of the imagers. Professor Anderson asked one of our imagers how confident, and they said not very confident. But I think once you know the anatomy, my opinion is, could you be missing a thin layer of ventricular myocardium? We know that in the normal heart, there can be variability in how much subaortic infundibulum is retained. So could you miss a thin layer of myocardium where you're not sure if there's really fibrous continuity or not? Sure. But I would say 99% of the time, when you know that detailed anatomy that we went over, you should be able to tell with confidence whether you're seeing fibrous continuity between the AV valves, the tricuspid and the aortic valve, or whether there's muscle there.
If I can come in there, Justin, I thought that the way you started us off with the normal heart, and you illustrated the components of the central fibrous body. And as you say, when you look at that in the different planes that you emphasized, and then you relate that to when there's a defect present, I think the point you're making is that based on that normal anatomy, you can almost predict whether there's going to be fibrous tissue or where there's going to be muscle tissue.
Exactly. And I would say as an echocardiographer, you have to get your hands on the heart specimens, the 3D models, and you have to start to conceptualize exactly the exercise that we tried to go through there. You have to start to conceptualize how you're cutting that complex three-dimensional structure in two-dimensional planes. And we could generalize this to all of cardiac anatomy. And then as you, instead of just describing, for example, muscle bundles in the right ventricle, when you start to understand how you cut the septomarginal trabeculation and its limbs, how you're cutting the septoparietal trabeculations, then you can start to really tease out this important, very important surgical anatomy.
Adrian, are you happy with that?
Thank you. Yeah. the next question is, we've seen different ways of defining the areas of the right ventricle septal surface. And I've seen one image today where it appeared that the apical trabecular area goes all the way up to the pulmonary valve. In other images, those who are viewing this, they might remember that it's sometimes shown as radiating from the central perimembranous area, where there is no confine between the inlet and outlet, whereas other images will show inlet and outlet sharing a common border. So which one is the real definition of these areas that you are talking about?
Well, you make a very good point, because there is no real anatomic landmark that separates the infundibulum from the apical trabecular component. But we know, I mean, and you know, Adrian, that when you are in the operating room, you can take away the entirety of the subpulmonary infundibulum and you can use it as an autograft in the Ross procedure. So what landmarks would you be following there? Because in many ways, that is surely the key to where we lose the apical trabecular septum and we come into the freestanding infundibulum. Adrian, are you still with us?
Okay, so if Diane or the participants, they have other questions.
I mean, how do you, when you're doing the Ross procedure, I mean, what are the landmarks you follow there? I suppose because the infundibulum inserts between the limbs of the septomarginal trabeculation, but the septomarginal trabeculation can overlap the infundibulum, can it not? So what are the landmarks that you're looking for when you take away the pulmonary route?
And Dr. Quintessenza is here as well. Maybe he could.
Good morning. We're just tuning in. I just heard that question.
Nice to see you.
So we were talking about the ambiguity of the how to divide up the inlet outlet apical trabecular portion of the right ventricle, and Professor Anderson was asking, and I would say one of the confusion you point out, Adrian, is the colored image that I marked where I brought that apical trabecular portion up almost all the way to the pulmonary valve. And I would say why I did that was I used the septomarginal trabeculation and its limbs and everything below that not being the outlet, and everything within the limbs extending up to the pulmonary valve as the outlet. But Dr. Quintessenza, the question was for the Ross procedure, what are you using as the landmarks when you dissect out the pulmonary root as an autograft to understand where the infundibulum?
Well, you know, we're thinking of the implantation of the autograft, and we just want to have enough muscular tissues to basically sew below the valve and not infringe on the valve tissue. And it's an indistinct plane, right? We actually go 2-3 millimeters below the hinge points of the valve leaflets and kind of come across at that level. And it's just merely because that's kind of what we need for the cuff to sew it in, actually. So.
But I mean, it's a point that you make, Hugh, that really you're leaving enough muscle. But when you do that, you'll be taking away part of the cranial limb of the septal band, because that overlaps. Right. The subpulmonary infundibulum.
Right. Correct. It kind of merges in there, and you know, we come across that, you know, as well a little bit. But I don't know that it's not like a distinct zone of transition. I think it's kind of one leads into the other, it seems to me. But.
And this is part of the trouble, that, I mean, when we describe the inlet, the outlet, the apical part, there are no discrete anatomical boundaries between them in the normal heart. And in many ways, they don't become differentiated until you see the malformed heart. And I mean, some of the hearts that Diane was demonstrating beautifully showed the way that the defect then opened between the limbs of the septomarginal trabeculation, showing it was an outlet defect, or else open beneath the septal leaflet of the tricuspid valve, identifying it as an inlet defect. So I guess that the the parts of the ventricle become more obvious when the heart is malformed than when it's properly formed.
That's exactly what the study that Adrian that you had led showed, right? That there is a gray zone when we try to define the RV geography. There's some ambiguity to it, subjectivity to it, where defining the borders becomes more objective.
Yes, indeed. And of course, it's a septomarginal trabeculation, and defining its limbs, I think both the body of the trabeculation and some of the parts of the limbs are part of the septum, obviously, but then the end of these limbs are losing themselves outside the septum, because one will go and meet the ventricular-infundibular fold, and the other one will go in the free infundibulum. That area where that loses the septal connection and become parietal or become a non-septal structure is important.
And that's a good point you make there, Adrian, because as you say, when it moves up to the pulmonary valve, it overlaps the septum, but then it also overlaps the infundibulum. So although we call it the septal band, in many ways it's no longer septum. And it's a very good point you make. And as you say, it also extends parietally, and that used to be called the parietal band, but that itself became a contentious entity.
But I think the presentation today was quite clear, and grouping the specimens with what Justin showed in echo and CT is wonderful. I think at this point, clinicians should find it a bit easier to work around these definitions, because there is definitely much less confusion than in the past.
One hopes that's the case. I mean, one of the questions that was posed was whether these sessions are being recorded and are being held on the website, and it is indeed the case. My understanding is that our discussion is also being held. We had a relatively few people directly participating with us. We have a question from Jason Tan, who says, how does the conduction axis as the medial papillary muscle is on the other side of the septum? Well, in fact, in straddling tricuspid valve, the conduction axis runs along the crest of the septum, which is in the right ventricle because the valve is overriding. And then in many ways, if you look at the crest of the septum, you can see its point of branching. So then the right bundle branch runs all the way up and reaches the medial papillary muscle. And I think Diane showed that very beautifully in the particular specimen she showed from the Idris archive. And Justin then used that image again when he showed the computed tomographic data set, which I thought was a wonderful correlation between the two. Diane or Justin, do you want to make any further comment about that?
No, I don't have any other comments.
The presentations were spectacular, I thought.
I guess since we have Dr. Quintasenza here, just the risk, we always talk about the long, Diane mentioned the long non-branching bundle. What has been your experience, Dr. Quintasenza? Often those are the VSDs sometimes that cannot be septated. And I've seen a lot that go down a Fontan palliation, but in the ones that you have tried to septate, what has been your experience with risk of conduction damage with those perimembranous inlet VSDs with malalignment of the atrioventricular septum?
Yes, I kind of must say I kind of joined late, so I didn't see the presentation. So, but just in general, are you speaking of straddling tricuspid?
Yeah, with straddling tricuspid valve, where that conduction, the AV node is displaced anomalously, and there's a much longer non-branching bundle that runs much longer course around the margins of the VSD. We always talk about those being higher risk for conduction damage.
Yeah. So I think we just have to be a little further away from the rim, in terms of our bites, and to try to stay further away on the right-hand side. And just, that's what I would think to do. I must say it's a relatively rare situation. I don't recall having heart block with it, and then maybe I was just lucky, but that's kind of what I've done.
Adrian, do you have any more thoughts?
Just a mention about those inlet defects where there is really no inferior wall left. They look like they are bordering directly the free wall. Do you want to comment on those?
Well, you're
Because they're
right there.
different.
That's a very good point, because in fact there is no inferior border. It's being overridden by the tricuspid valve, and it is the free wall that's inferiorly, and that's where the septum comes up and joins the inferior part of the atrioventricular junction.
Sometimes it's difficult to distinguish from an AVSD type of defect.
Indeed, and in fact, the difference, of course, is that there are separate atrioventricular junctions, and for a long time they were considered to be an atrioventricular canal type defect. But we now know that the differentiating feature between the two is the commonality of the junction versus the separate junctions, and we'll move on to that in our final session, which will be in December. But next week we will we'll try and put everything together. I hope that Justin and Diane will be able to present material that will bring everything we've been discussing over the past 3 weeks, because it has been quite complicated. But hopefully next week we'll put everything together. So thank you all for being with us. And in 2 weeks' time, November 17, we will complete our journey through deficient ventricular septation. So thanks to you all for being with us. Thanks for those who've been listening for quite a long session, but I think a very informative one. Thank you very much.
Thank you. Bye.
See you. Bye.